professor at Andros Clinics Arnhem in Netherlands. Professor BARENTSZ is highly specialized and a reference in the field of prostatic imaging. He was a past president of the European Society of Urogenital Radiology. His talk is entitled Current Controversies and Future Perspectives of Prostate MRI.
Okay. Thank you very much for your kind invitation to give my talk here on prostate MRI in Hurghada. It's a pleasure to share my knowledge. Okay, let's start. First of all, I have no disclosures. My presentation will be on the timeline. You can see here it started in 2000 to 2030 of prostate MRI. I will talk a bit about the status of local prostate MRI, multiparametric MRI. I will just say a few words on how it started with BARENTSZ. I will talk a bit about quality. I will give you some ideas of a future version of BARENTSZ, my view. And finally, I will end up my talk with artificial intelligence. Let's start with number 1. Local MRI should be done with multiparametric MRI. Multiparametric MRI is the integration of 3 MRI techniques. So you use them together, like the 3 guys here climbing this mountain. You have, first of all, tissue structure, T2. You can see nice anatomy. However, specificity is low, and therefore we also are looking at cell density. That is diffusion-weighted imaging. With diffusion-weighted imaging on the ADC, a black hole means reduced velocity of water molecules, high cell density, and cancer, aggressive cancer. Finally, we have vascularity showing the vascularization, and both in inflammation, benign prostatic hyperplasia, and cancer, this is increased. So we use them together. Number 2, about 10 years ago, we started to see that we should look and report MRI in a similar way. That is why we developed, together with a group of European uroradiologists, BARENTSZ version 1. BARENTSZ means the assessment category. Each lesion is assigned a risk on a 5-point scale. That findings on T2, diffusion and contrast enhanced MRI, correlate with the presence of a clinically significant cancer at a certain location. So not any cancer, no, clinically significant. 1 is low and 5 is high. 3 is I do not know. This led to an international version 2 published in European Urology in 2015. This was a very highly cited paper and awarded, so a lot of urologists were looking at BARENTSZ version 2 and now use it into the guidelines. With BARENTSZ version 2, there was a different weighting for the peripheral and the transition zone. In the peripheral zone, diffusion dominates, and in the transition zone, T2 dominates. I will show more on this in my workshop tomorrow in Hall C at 9:30. With BARENTSZ, we try to keep things simple and stupid. So a simple way to look at images. This led in 2016 to 2019 into the version 2.1, where there were minor additions. Most importantly, a lesion in the transition zone scored as a 2 could be upgraded based on diffusion to a 3. This was actually the most important change. Now, what is the scientific evidence of local MRI? There were many keynote level of 1 evidence papers which led to the change of the guidelines. There was a Cochrane analysis. With MRI, instead of systematic biopsy, you can avoid biopsy in 33% of men, with a very high sensitivity in detecting significant cancer, 96%. There was a significant decrease in the detection of insignificant cancer. And the detection of significant cancer was equal to systematic biopsy. So MRI has a lot of advantages. If you have an experienced group, in half of the patients, you do not need the 12-needle biopsy anymore. If you have an implemented technique into the clinical world, into expert centers, you can go even up to 60%. So many men will benefit if you introduce MRI. And that is also why MRI is cost effective. In 2019, the European guidelines of the urologists changed, and 1 year later the AUA guidelines changed. And now it is in the guidelines that prostate MRI needs to be done before biopsy. What are the challenges? This is nice news, isn't it? But we have some challenges. And we now are in the world of 2023. The tsunami of MRIs is coming at us. So please be warned. Every 5 out of 1,000 men has an indication for an MRI. And that is a lot. The most important thing is that not all the radiologists do it well. So, what about quality? If you look at an expert review of prostate MRIs, you can see that the number of clinically significant cancers here in the orange area is higher, the detection, as compared as the non-experts. Proof that expertise matters. If you want to read how to make a nice image, you can go to European Urology. My chief technician wrote it down. Here you see in part 2 the interpretation, how to read an image. Here, how to biopsy in a transrectal way. And finally, how to do it transperineally, the current standard of the EAU. Google my name and European Urology and you will find those 4 papers. What urologists need to know about MRI. So, quality matters. First of all, we need to measure image quality. How good is your examination that you're looking at? Usually we don't do that, but this is important. Second, we need to train urologists and radiologists. We need to certify prostate radiologists, and we need to certify persons who are doing the biopsy. And we have to have accreditation for the centers. This is important, and this is going to happen in the next few years, I hope. So how do we measure image quality in an objective way? For this, we have written a paper, Consensus European Urology and Radiology Worlds, and the statement was to ensure high quality prostate MRI, checking and reporting of image quality is mandatory. So you should mention this in your report. How good or how bad is it? Now how do we do that? PIRATES version 2 is an objective way in looking at images. It will come out very soon. It is looking at T2, diffusion and DCE, just like PIRATES. And there are 4 points to be earned by T2, 4 by diffusion and 2 by DCE. If any technique scores of diffusion and T2 less than 3, it is not good. So you look at the signal to noise ratio in the periprostatic fat, yes, no. You look at the clearly delineation of relevant prostate tissues, the absence of artifacts, and the quality of the sagittal or coronal images. For diffusion, we look at the adequate SNR on the high B-value images. So do you see a bright spot, yes or no? We look at the contrasts in the ADC, whether we can discriminate the transition from the peripheral zone. We look at severe artifacts, and we look at susceptibility artifacts where we have a discrepancy in the size of the prostate and shape of T2 and diffusion. Well, with DCE we look at the enhancement. Is the quality good enough to allow to see enhancement in time, and can we identify anatomical structures, for example, the pudendal artery? So this is a way, and you should, well, have it, this will be out very soon to test it. Mention this in your report. I'm doing this routinely now every day. An example, you can see over here that there is a little bit, well, blurry due to motion artifacts on T2. The coronal and the sagittal images are not that sharp, so T2 will earn 3 out of 4. However, there is not a really bright area of this tumor here as compared to the rest, and there is not an optimal delineation of peripheral and transition zone, so 2 out of 4. That means that the DWI is not sufficient, and in this examination, contrast was not performed. This is a case we see too often. This was reported, a man with an elevated PSA, very high negative thrust biopsies. This was reported as a Pirates 4 lesion. And the advice was, let's do a biopsy. Well, you shouldn't do that, I think. Because this is an encapsulated lesion, which is not a 4 but a 1. So, wrong read. Second of all, there's another lesion. Do you see it? Well, look at all the images, and if you look very closely, you can see something over here. And if we now go to the slice of the other images, you see that there is a small lesion here, which is dark, slightly bright, and also focal, so Pirates is either a 3 or a 4. Biopsy showed a very aggressive tumor. So urologists are not happy. We should work on that. 4. Pirates. The BARENTSZ view. Definition of clinically significant cancer, contrast and no contrast, read with clinical risk, quantify if value images, and additional biopsy needed or not. Okay, the definition of clinically significant cancer. There are many definitions of clinically significant cancers, according to the urologist. The definition we use is a Gleason 3 plus 4 or higher. In the Pirates, it is meant that you should have a prominent but not a predominant Gleason 4 component. What does that mean? What is prominent and not predominant? It's not really defined. So you can have a 3 plus 4 where you have a 1% of 4, which is unlikely to be a very aggressive cancer, but also it can be 49%. These are the same. The first one you will not see with MRI, the last one you will. Nonetheless, both are called significant cancers. You actually will see something when there is at least a 25% of 4 component in your biopsy. So, this is, for me, clinically significant. Contrast to DCE or not to DCE? That is the question. Well, a nice paper of our group showed that you can do, instead of 2 MRIs, 4 MRIs per hour, if you skip contrast and a few other sequences. And you will see that the only thing is that the insignificant cancer is slightly improving. The uncertainty is increasing, so you do 2% more unnecessary biopsies. But that's all. Equal sensitivity and equal specificity. So contrast is good, but you can delete it. Can't you? Well, according to this paper, yes. You have no allergy, no gadolinium brain deposition, lower cost, easier. However, you need expertise, because if you don't have an expertise, you need to have contrast. Contrast will help you. For the experts, it is not that helpful. However, for the non-experts, or when the MR is not optimal, you do need contrast. And I need it still every day. So, contrast helps to find the tumor, is reducing uncertainty, and is especially helpful in less experienced radiologists. Clinical risk. According to the Pirates, you should not look at the clinical risk when reading the images. That is what I do not know. When you have a high suspicion, that means a PSA density above 0.15, a low free total PSA ratio, you have genetic predisposition or a positive DRE, I'm looking differently at the images. The cutoff value for PSA density is 0.15. This is important to memorize. This is a BARENTSZ 2 lesion, and the question is, should you biopsy? Well, you don't see a lesion, don't biopsy. However, if I tell you that the PSA density is much too high, I call this a dirty BARENTSZ 2. I look specifically at the washout, and then I'm going to stick in a needle, and this is a positive lesion. So, clinical information matters. Now, if you have a biopsy-naive patient, high specificity reading to rule in tumors is very important. You should reduce the number of unnecessary biopsies, so the number of false positives is even more important, because these men will have, well, the effects of biopsy if you have a high false positive rate. So high specificity reading in these patients is important. You don't want to overcall a lesion. In a post-negative thrust biopsy, you really want to find the tumor. So high sensitivity reading is more important. You want to decrease the number of false negatives because the patient has a high clinical suspicion. You really want to find the tumor. So the clinical scenario does matter. What do I recommend? In 1 and 2, BARENTSZ, don't do anything. In 3, only do a biopsy if the PSA density is above 0.15. And in 4 and 5, consider to do a biopsy. In all the patients, you need to do at least a follow-up of 1 year of their PSA, because if you do miss a tumor, usually the PSA gradually increases and you will find a patient in the second round. Quantification of diffusion. What is markedly hypointense? What is markedly hyperintense? Well, you don't see a lesion on the ADC and on the B1400, do you? However, if I play a little bit with the window and center, you see the following thing. Whoop, there it is. A black hole and a white area. So, instead of nothing, BARENTSZ 1, it now becomes a BARENTSZ 4. How can I do that? How can I solve this issue? Well, what we do is we measure the lowest ADC value. And I know from my machine that the cutoff value of Siemens 3 Tesla and 1.5 Tesla is 900. And if it's something above, it is either normal or a Gleason 3+3. If it's lower, you can be sure that it is a significant cancer. So in this patient, with a value of 1000, I call it a BARENTSZ 2. Ultra high B value. If you look at the low B value, you look at the vascularity. We are looking with prostate MRI at the B1400 or slightly higher. You look at the water in between the cells, so cell density. However, you also can look at the ultra high B value. There you see the intracellular water diffusion fraction, so the exchange of water in and out of the cells. And where is that helpful? That is helpful in the very difficult transition zone lesions, where they, like BPH, have a high B1400 and a low ADC. However, the cancers do show up at B5000, whereas BPH does not enlight at B5000. So this is very specific for cancer. Signal intensity at the calculated B5000. Just try it. We did biopsy this lesion at the bright spot at the B5000, and it was in Gleason 3+5. Significant cancer. How should we target the biopsy? Random, with ultrasound, targeted, focal saturation. There was a nice paper in the New England Journal recently from the Swedish colleagues. They showed that an additional thrust biopsy only gave 3% more of clinically significant cancers and also a bit more of insignificant cancers. So thrust is not really helpful. So my advice, no random thrust biopsy in the BARENTSZ 1, 2 and 5 lesion. Focal saturation in small PIRATs 3 and 4. That means just not 2 or 3 needles, but 4 or 5 needles in the area of the tumor, which is small. These are small lesions, diffuse, heterogeneous, anteriorly located or in large glands. Or when you are not an expert, stick in more needles, because you will have a biopsy error. Finally, if you do focal therapy, you can consider in doing a random biopsy if you really want to rule out other cancers in the other area. Don't forget that in good hands, your negative predictive value of MRI is 97%, which is very high. So even in these patients, we at our institution don't perform random biopsies anymore. It's the end of random biopsy. 5, final part, artificial intelligence. It will make MRI faster and better. We can work on 2 areas, that's the acquisition and the reporting. Let's start with acquisition. With no artificial intelligence technique, the examination time of these sequences is about 15 minutes. Using artificial intelligence, it will go down to 8.5 minutes. So this is something in the future. Artificial intelligence directed techniques. Also interpretation. In this patient, we are not sure about the diagnosis. However, artificial intelligence can help and gives us a probability map that there is a lesion. And now we can look at the images. Is it a lesion, yes or no? So we rule out lesions based on AI. This is the most recent publication on AI. This is of the MR first paper. The ADC is not bad. This is of the PROMISE trial. This is of the MRI first. I'm almost ready. Here I see the data of our 4M study, and this is with artificial intelligence. So you are getting pretty good. Now, the last slide on AI, the limitations and the advantages of AI and deep learning CAT studies. There are promising results against radiology and also for histopathology. The detection of high-grade cancers and segmentation of the gland is very good. It is commercially in the academic and it's becoming available. However, is it ready for prime time? No. There is a too optimistic performance of the overfitting and limited diversity of data sets. There is a minimal independent external validation of developed systems. There are challenges of the data sets. We need to have more and better data sets. And head-to-head studies compared with the current PIRAT standard based on multidisciplinary care are lacking. And finally, last but not least, who is responsible? There are legal and ethical issues. What will be the future? This is a clear PIRATS 4 lesion. Focal abnormal, plus for contrast, white on B3000, black on ADC. Well, this is PIRATS 4. However, if you ask the computer, you'll get the following data. It gives you a probability in percentages that it will be a significant cancer. So this is not a PIRATS 4, but in the future, in 2030, I think we will leave PIRATS and we will have the AI percentage mapping, probability map in percentages. Is MRI the enemy or is it the friend? I think it's our friend. AI will reduce our workload. It will reduce and help to delete and the BPH diagnosis and prostatitis diagnosis. That will be done by the computer. So the boring cases will be done and recognized by computer. And it will improve our performance by double reads, just like a pilot, an automatic pilot of AI of our reading. So, in 2030, we will have the integration of clinical data, risk calculators, liquid biomarkers, and artificial imaging. And this, finally, with an AI technique, will develop the risk percentage of clinically significant prostate cancer. This, I think, will be the future in 2030, not forgetting the very important role of the radiologist in this pathway. MRI is the best biomarker for clinically significant cancer, will further improve. We need quality control, period. And percentage AI risk assessment will take over. Thank you very much for your attention. This is one last warning. This is the DRE for the radiologist. What does it mean, DRE? Develop? Radiological? Expertise. Okay, this is it. Thank you.
Thank you, Professor BARENTSZ, for the very informative presentation. We will postpone questions to the end of the session. Now we'll move to the next speaker.